today is also special because we are talking about something that the group, which has been incubated within CORE Net, the first FLWs working group, is going to share some of their evidence synthesis sharing with you. So before we begin, I'm just going to share with you a few ground rules for today. We are recording this session for documentation and sharing. So if you'd not like to be recorded, please leave us a message in the chat window and we'll make sure to remove every time you use your voice or message. At the same time, in case if you have an AI assistant, please let us know and we'll need to seek consent from the group. To save bandwidth, it'd be great if you could turn off your video and keep yourself on mute while you're speaking. We can speak both English and Hindi. तो अगर आपको हिंदी में ज़्यादा आसान लगता है हमसे बात करना, तो प्लीज़ उसका इस्तेमाल करें और हम सब आसानी से बात कर सकते हैं. We do have ample time in this session, about 20-25 minutes for discussions. So in case if there's anything you find within the presentation that you'd want to share or ask about, please leave a comment in the comment section. We'll keep an eye on that as we go ahead. What we're going to do is just very quickly introduce to what the process has been. Then OPM takes us through some of the findings as they're emerging from the FLWs working group, and then we leave some time for discussions. All right, we've done this many times now. It's the 11th session, so I won't go in much detail, but all details for CORE Net you can find on the website, which is www.corenet.in. Please have a look, and we're also very active on Slack, so join the Slack workspace and explore all the different conversation that's been going on. Coffee hours happen weekly. I will give a caveat to this in the end as well. The next coffee hour is not on Thursday, but on Tuesday. And it's a really special session because we're going to be speaking to two IRB panelists talking about adaptations that they've had to make to move a lot of their researchers from in-person surveys to phone surveys. So that's a really important conversation. It'll be interesting to share. Today's conversation is about working groups, and working groups really came through sometime in August, where we said that there was a need to also, while we were bringing a community together, there was a need to deepen the collaboration and find out what shared objectives were among researchers working on similar themes. And then if there was an opportunity to think about shared research outputs, that's what we had set out to do. This one is a working group on frontline workers, and the intention is for them to explore what different outputs could be, also to create a database of organizations working on frontline workers in India at different scales, and also then to figure out what could be starting points for conversations with different stakeholders such as researchers, policymakers, and members working on the ground. This working group is led by OPM, the Oxford Policy Management Limited, and they work extensively on frontline workers, especially with a focus on Bihar. And they have been tasked with the idea of steering the working group activities, identifying and leading the key outputs, as well as opportunities for evidence sharing with different stakeholders. And with this, I will pass it on to Radhika from OPM, who will take us through a few slides and talk to us about what the working group has been up to. Over to Radhika.
Many thanks, Rohan. Thank you, everybody, for joining in. Just a quick overview of this afternoon's session. We will go through the context of the content of the presentation and the objectives of the exercise with a brief overview of the methods, and then going on to the themes that have emerged from the evidence review, followed by an interactive discussion and what the implications of this evidence review mean for the work of the thematic working group, policy and program. There is, of course, as Rohan mentioned, lots of time for Q&A and for next steps. Next, please. So this evidence review is one which focuses on the role of community health workers in the COVID-19 response in India. So within the context of India's COVID-19 response, and it emerged as one component of the activities that the thematic working group on frontline health workers is undertaking as part of the CORE Net group. I will use the term community health workers and FLWs interchangeably, but like we've discussed before, because FLWs is a very broad term, which encompasses different cadres of health workers. We will focus this presentation and the content in it focuses on community health workers, particularly the three government cadres of community health workers, the ASHA, the Anganwadi worker, and the auxiliary nurse midwife. So just a brief context, the first case in India was identified on the 30th of January in Kerala, and by March it had spread to different parts of India. Delhi had its first case, I think, on the 4th of March. By the 25th of March, India went into a lockdown, one of the most stringent in the world. Unfortunately, one of the major impact of the lockdown, particularly since everyone only had a 4-hour notice, was the sudden loss of all activity, and which led to immense uncertainties, of course, amongst the internal migrants. And we witnessed a mass internal migration amongst internal migrations, which has its implications for how the disease spread, and for some of the findings that we will present later. The lockdown also meant a loss of employment and income across rural and urban areas. There were immense challenges to mobility. And of course, there was access to routine and emergency health services was severely curtailed, both in terms of facilities and the system gearing up to address the COVID-19 outbreak, as well as other challenges, for example, inability, lack of public transport, etc., on the ability of people to access health services. And so, much like the rest of the world, COVID-19 has highlighted the need and relevance of strong health systems. And the human resources for health has emerged as a critical component of the health system towards a resilient and responsive health system. Community health workers, particularly in the Indian context and also in the context of other LMICs, have emerged as very, very important health components of the health system and as health workers in the context of responding to health emergencies, and in our case, COVID-19. And so formally, within the Indian context, the role of community health workers has been to generate awareness and IEC activities. It has been to support with surveillance, contact tracing, and monitoring of people under home isolation. The community health workers are also expected to undertake routine health activities. Next slide, please. The evidence mapping, this evidence mapping emerged from a need to understand, at least within the group, what are the areas that we have worked on community health workers and their role in the COVID-19 response. And strengths, what are the key strengths? What is the work that we worked on within the group that we can sort of leverage to collaborate on pieces of outputs that would be relevant to, let's say, program and policy, but also to understand what are the gaps in evidence and collectively outline actionable points for further research or study for policy and program. Next slide. In terms of methods, this was a rapid review. We reached out to thematic working group members and requested them to share with us documents that they might have produced over the last few months on CHWs and COVID-19. We sourced, TWG members posted on the Slack channel. They sent us information via email. We shared, and also during the course of TWG meetings, we've had 4 meetings so far. In addition, we've undertaken a desk review of documents, just peer-reviewed and other literature on CHWs and their response to COVID-19 in India and outside. This particular mapping includes 16 studies by 12 organizations, and a big thank you to all the thematic working group members who have contributed to this. And thank you for sending us your studies and engaging with us. And thank you to Sambodhi as well for helping us with the methods, and of course the OPM team who worked together to produce this. And the studies include those pieces of work that focus on CHWs within the context of COVID-19. We have excluded, we've excluded studies that do not on other frontline health workers. And I can't actually see the rest of the slide. The majority of studies here actually included in our review took place between April, May, June, and July. October, of course, since it was so recent, we don't have as many. But this sort of tended to taper off a little around July, August. Next slide, please. So a big thank you to all the
just
member
a quick
organizations.
question.
Yeah.
Can you see the slide? Okay, the bottom half of the slide is cut off.
The bottom half is cut off, yes.
Right. Okay, sure. We'll just go over this and see. In case if it doesn't get fixed, I'll request Nithya to share. Thanks.
Sure. I think it's probably could be the aspect ratio or something, maybe. I just feel like
I don't think it's cut off, is it?
Yes, the previous slide, the last line was cut off, but I think this one, I don't know. But these are these are member organizations of the thematic working group and whose studies we have included in the mapping and who we engage with. So big thank you to them. Should we move on to the next slide? Thanks. The geographies covered as part of the review included Bihar, 13 states, but the bulk of the evidence that we found, at least in the work that we've undertaken, were from Bihar, Jharkhand, Madhya Pradesh, and Rajasthan. And these are also some states with relatively poor health indicators. This is an animated slide, so I think if you just click next, the map will show up. Thanks. And so what are some of the key emerging themes? We can go on to the next one, that's fine. What are some of the key emerging themes to have, what are some of the themes to have emerged from this review? And these are largely on roles and responsibilities, on service delivery and provisioning of services, as well as the health system perspective towards this. We also there's also evidence on community level engagement, on CHW incentives, and on the safety and security of community health CHWs while undertaking their tasks. Next slide, please. In terms of roles and responsibilities, and indeed, in fact, for many of the other themes, some of the findings are not really, the findings are not really dramatically different from regular days, but within the context of COVID, and in this time, the role of the CHWs included both COVID-related activities, such as IEC, surveillance, contact tracing, and monitoring, along with regular activities. There was a slight temporal change in the focus on roles and responsibilities. So earlier on in the lockdown, in the initial periods, March and April, where mobility was severely restricted, and the outbreak was relatively new, much of the activities focused on their COVID-related roles, which is, generation, community engagement, and also surveillance and monitoring, because there was this mass internal migration that took place at that time. Routine services were stalled to an extent. By the first week of May, routine services began resuming. So for example, immunization began at the time. And from then until now, gradually routine services have resumed, and now CHWs navigate both areas of work. And so the current workload includes these two. However, there is a need to sort of ensure COVID-related, COVID-specific precautions and train and support CHWs with this. And also, we, anecdotal evidence did sort of tell us that there was some amount of catch-up needed as a result of the stalling of services in between. Could we move on to the next slide, please? In terms of service delivery, CHWs reported a disruption in supply chain. And again, this was a result of the lockdown where mobility was hampered, and then everyone was scrambling to sort of get things moving and adapt to a new way of working under new circumstances. There was, health and nutrition services were impaired. And referral services also suffered. So not just because facilities were gearing up for COVID, some did not even accept non-COVID cases, but also really simple, if mobility is hampered, then how do you even travel to health facilities? There were breaks in home visits, in ANCs, if there were changes in the way take-home rations were distributed. But of course, I mean, the demand for health services did not stop from the community perspective. The one thing to note was that CHWs really, used what I would say personal ingenuity and they adapted to the circumstances and used innovative ways in which to provide health services to the best of their abilities. Next slide, please. In terms of the community response, initially there was a sense of fear and uncertainty with good reason amongst community members, and I think CHWs at this point played an important role in sharing awareness and in terms of engagement. Some of the evidence indicate a change in the community CHW relationship, indicating a greater sense of trust amongst communities in the information that the CHW was sharing. And also at this time, navigating the challenges, the communities navigating the challenge of loss of income, mobility changing. And there was, of course, at some points I'm missing here, there was also a negative side, like CHWs did face stigmatization. They were often people often the community referred to them as carriers of COVID. There've been instances of violence against CHWs, particularly in terms of reporting COVID positive cases or navigating the space where getting people to go for tests, for example. Next, please. Incentives at the beginning of at the start of around March, the government introduced specific incentives of 1,000 rupees for ASHAs and 500 for ASHA facilitators for COVID-related activities. A general health insurance, I think 50 lakhs was also offered to health workers responding to the COVID-19 crisis, and this covered community health workers. But in line with the historical challenges of incentives, there were, community health workers, ASHAs did report not knowing what the entitlements were. There were variations in this report, and also how much was due to them and whether they actually received this incentive or not. There was also variation in the ASHA workers' knowledge about their entitlements regarding health insurance coverage during this period. Next slide, please. Safety and security emerged as a significant challenge for community health workers, but as we said, many adapted. So we heard of community health workers, and the evidence reflects community health workers creating, for example, producing their own masks, which they use for themselves as well as for the communities. Community health workers are formally placed as low risk within the health worker categories for PPEs, and they are entitled to masks and hand sanitizers, and I think gloves in terms of the formal entitlement levels of PPPs. But even these were available inconsistently, and in many cases, the evidence has reported that CHWs got only one mask, which they were expected to use and reuse. And so it merits a sort of investigation into what the needs of the CHW, from the supply side, to enable them to carry out their tasks effectively. And in terms of one of the positive factors to emerge from the evidence was that supervision was seen to improve and support service delivery, and the method of supervision during this time, particularly given that people couldn't move around as freely, was over the mobile phone. Next slide, please. So what does all of this mean? You know, we've had a slide description. Next slide, please. In terms of roles and responsibilities, well, the evidence suggests that there is a need for greater clarity on the role of the CHW. What is it that she's expected to do? How is she to navigate this? And what are the interactions between the different CHW cadres in terms of roles and responsibilities? There is also a need for adequate training and support. And this also ties back into the context of safety and security, because, you know, particularly as routine services have resumed and COVID has not really disappeared, how do you equip the health worker to provide and undertake her roles and responsibilities in a way in which she's given the necessary skills and support to be able to undertake her work safely and effectively. Also, there is opportunity to investigate the use of separate cadres for other services, for example, for contact tracing and identification of potential of people who might have been exposed to COVID-19, which, you know, because currently CHW is also supporting with contact tracing, so it's an opportunity. And, you know, routine updating of information to support her with her IEC activities, because it is really important to realize that the pandemic is not over. You know, some of this also as talks begin about how, you know, preparations take place for hopefully a potential COVID vaccine to be approved in the next few months, and the role of CHWs in that. So both training and providing training and support would be necessary. Peer support emerged as a missing piece, and there are perhaps opportunities here to find pathways to enhance this component. And there's also perhaps an opportunity here to leverage community engagement. You know, if trust building is something that emerges as a positive, it can be leveraged this for the future as well. Mostly we saw that it was the CHW's intrinsic motivation and drive to deliver services in these extraordinary circumstances that was really a driving factor. Incentives, there are opportunities to streamline incentives for performance-based remuneration, and this is not just you know, particular to COVID, but in general. And one of the things to emerge from the evidence review, which is the use of mHealth applications, both for training and as job aids. So could we also leverage mHealth applications for streamlining incentive payments and even for reporting of activities? And again, reiterating the need for all of this to tie in with the safety security of CHWs, perhaps even use mHealth applications to support CHWs in undertaking her tasks and with skill building. There's also a need to focus and sustain psychosocial support for health workers, including CHWs. What emerged as a significant gap in the evidence review was the limited application of the gender lens within the studies that we had. And this is particularly critical for, you know, for this gendered cadre of health workers. So this is something that emerged as a gap, and, you know, would have bearings would have bearings essentially on program and policy in the long term. It is also important to strengthen service delivery to reduce the impact of COVID on girls, women, and other vulnerable populations. Next slide, please. These findings, some of these findings, like I mentioned before, are not really, you know, it might not be surprising for many on this call. And, you know, we found some of these challenges in general CHW services, service delivery as well. And they also fit in with so a couple of years ago, OPM had a paper on the means, motives, and opportunities framework, where it was realized that motives were not really a binding constraint to CHW performance. And so some of these findings also reflect back on the opportunities and means where there are opportunities to strengthen these to improve and support CHW performance. And so what are the implications for this, for the thematic working group? You know, does it mean that we should sort of undertake a more realistic review of CHW roles during health emergencies? Or how do we create a cadre, or how do we create program and policy that strengthens this cadre to be more responsive and have more capacity to respond during health emergencies? Some of the areas to emerge was on strengthening supervisory mechanisms and to leverage digital technology for support, for training as job aids, and as we mentioned before, for incentives and to enhance peer support. Another opportunity or implication would be to perhaps invest in the technical and soft skills to support CHWs during this time and also post-COVID, and increase the gender lens in health workforce studies. But the question actually still also remains on empowerment. Next slide, please. And so this was a very brief overview of some of the findings from an evidence review. This will be built upon, and we will develop this further as a group. And we would like to collaboratively engage as a thematic working group towards producing an output which summarizes these findings. And of course, work towards a dissemination strategy. Next slide, please. And now, if there are any questions on this, we would be happy to take those. Thank you. What's the next slide, Rohan?
That's just discussion points, but
okay, so if there are any questions at this point?
Yes. Yes, please feel free to unmute yourself, ask a question, or if you have reflections in case if you have work that is resonant with this, or if there are dissimilar findings that you have, anything would be interesting to hear.
Hi, Rohan. Priya has just asked a question on the chat. Priya, would you like to unmute yourself, or should I just read it out from the chat? Okay, she's unmuted.
No, you could have read it out. Just Radhika, I mean, thank you very much. That was a nice overview. Just wanted to know if you had to say, what are the 3 key research gap areas where future research should be directed? I didn't get that clarity. I got the clarity in terms of the gaps for interventions much more than I did. Okay. Is it these 3?
Yes, we were good. These are some of the key, I mean, these are not, there are other important areas as well, but we did feel, at least from the evidence review, very few applied the gender lens to the studies that they've undertaken, or at least present some of the findings within the context of gender. And also, in terms of psychosocial support and mental health, so how do we sustain psychosocial support for health workers in general, of course, but in particular now for community health workers following this, because there are some interventions that are going on currently, as we might know on this, but how does one sort of keep this, how does, there's limited evidence on this, and also supervision emerged as something that really that is an important factor for performance. And there are, also I think one of the things missing here would be digital technologies and taking that forward from beyond COVID over the next few years. Was that helpful?
Radhika?
Yes.
Can you hear me?
Yes.
Okay, I just want to say a lot of this is generally a concern for CHWs, COVID notwithstanding, right? Is there anything that comes out very clearly from your review that says during the time of COVID, this is the kind of research that basically tells us, amplifies what we know. These are new areas and we need to go deeper into these areas. So that, I mean, maybe that's just a suggestion for you as you do the next round. Would be good to just say, okay, this is what we knew, it's just getting reinforced. This is new insights. And these are areas that we still don't know enough about. And this is where future research should be directed. And one suggestion I have, which I haven't heard enough, and maybe the IWWAG people who are here can speak to that, is the whole issue of time use. Even earlier, we didn't know much, but now with additional roles and responsibilities, how are women CHWs managing their time? And do they feel helpless, out of control? What are they compromising on? Is it other essential work, or is it their personal time or household responsibilities? So I think, like, I haven't heard enough. If I don't know if anybody's done research on that. So that's just my suggestion on a gap area for me, and I'd love to hear from others.
Okay, thank you. On time use, some of the evidence did indicate about the temporal nature of this. Well, initially we thought that, initially they reported that the time constraints in terms of the burden, the workload was not that much because routine health services were stalled, and this has changed more recently. So the reports on time use changed a little bit. Some of the evidence, some of the studies did engage with this, not deeply, but yes, they did engage with this. But time use also within the context of gender and other social dimensions emerged because if she's also responsible for taking care of the household or the support of her family members in engaging with COVID-19 activities, did emerge. And these three components, and perhaps also the intrinsic motivation factor, really emerged strongly within the COVID-19 work. So, I mean, what my intention was that this is not removed from even general studies, but these did emerge as strong areas. For example, the gender lens and also supervision and intrinsic factors that encourage them to undertake their COVID-19 roles and really even under the difficult circumstances. So these are areas that warrant. Oh,
great, thanks. Pranita, you have your hand raised up.
Yeah.
Can please go on, and then whoever's speaking next.
Yeah, thank you, Radhika. It was really interesting presentation, lot of nice findings. I just wanted to reflect and also see if you have certain more insights around. So one is about this whole incentive, and I really feel the way lot of burden, work burden comes on frontline workers with minimal support. And with that comes like a token of incentive, which at times not really aligned to the type of effort expected from them, and not even consider at times as a performance-based payment. And this is like, for me, it is very gendered. There is a whole gender power relation that exists, and how they are really at a very low level with very minimal power that frontline workers have. Were there any reflection and insights and how frontline workers see this whole situation and scenario, the way they are working? And of course, you talked about the responsibilities that they have at home with minimal basic protection gears for them to really protect themselves going back to their home. The whole fear of how they may be carrying virus to their home, and also some of the push that they may have received from other households, the people in their own community and villages. So I just wanted to hear if there was something that emerged during the research. Right, I personally feel this is really important that we need to discuss more.
Indeed, thank you for that. This is actually one of the gaps to have emerged, like particularly when we, and I think in general CHW gender discussions, people always ask that if it was male CHWs, would there ever be a male cadre, a CHW voluntary cadre, male, comprising of largely males? But this is something that emerged as a gap in our evidence. And perhaps I could ask Shuchi to come in, and I think she was trying to respond to some questions. So Shuchi, if you'd like to come in right now, yeah, I will mute myself. Thank you.
Thanks, Radhika. I just wanted to respond to a comment that Priya had made earlier about the issues that perhaps got amplified, because historically some things were a challenge that seemed to persist even in the COVID context, right? But something that even Radhika alluded to, which emerged quite strongly, was the fact that intrinsic motivation actually allowed these frontline workers and these community health workers to respond to a very extraordinary situation wherein they were drawing on their ability to cope with these and design coping strategies, actually in these very challenging times forge meaningful trusting relationships with the community to actually deliver. So perhaps this is something that the MMO work also speaks about when we say it's not actually a problem of motives. It is actually an opportunity and a means level challenge which appears to persist even in a situation like a pandemic. So yeah, so I guess that thread, that argument sustains even in this scenario. Thanks.
Hi, Pranita. I think I would just like to come in and maybe respond to Babita also, as you mentioned about our study. So one aspect that we did study, but since our sample was not too large, we didn't go into as much detail, but we did touch upon the gender aspect, and we had anecdotal evidence from the FLWs wherein they mentioned at the peak of the lockdown where they were doing the survey with the migrants, they actually started cutting themselves off from their family. So they would sleep in the open courtyard, and they would stay away from their children for 3 days after having conducted the survey with the migrants, which now when we are beginning to conduct our second sprint is not the case, because now the risk perception has died down a lot. They still haven't seen COVID in their own proximal areas. And so now the fear of COVID has drastically reduced. So at the family front, though, they still have some opposition, but it is not as strong as it was during the lockdown, especially when they were working exclusively with the migrants and doing door-to-door surveys and helping with the organize the quarantine efforts. In terms of time, they did mention during our first sprint that the work that they now have to do has increased, because even though the general services were not taking place, the usual maternal and child health services, the work of survey required much more reporting, much more following up, and was supervised very closely. So that was on the basis of the survey. The other thing that Babita mentioned in the chat around absence of triggers was actually, this is with respect to COVID. So we actually found that apart from immunization, most of the other services, the community was very dependent on cues from the ashas. So if the asha will go and call for an ANC, the women will go. If the asha will remind them about the immunization date, they will go. If the asha will give them contraception, they will have an affinity to use them. But in absence of those cues, the community because we were doing both families and the FLWs, we saw a drop in intent for these services. And we constantly heard from the beneficiary side that it's only when the Asha Didi will come and say. So that aspect of their work and how pivotal they are in terms of mobilizing for all of these primary services, I think is something that needs to be highlighted. And as Radhika said, in terms of policy and taking this work forward for the future after COVID also, I think to realize what pivotal role do Ashas play, not in terms of just delivering the services, but in terms of mobilizing and coaching and counseling these families and making them and increasing the demand for these health services. I think that's one aspect that we should look at.
Great. Thanks for this, Monisha. We also have a question from Madhulika, which I think in some ways also ties to this. Madhulika, are you there? Would you like to ask your question?
Sure. So this is based on some anecdotal evidence I've heard from parts of North India that ASHA workers or Anganwadi workers who belong to lower caste, they have had trouble reaching out to people for contact tracing and for migrant surveys. Did you come across instances of that, of like similar instances where caste was intersecting with the already difficult work that they were doing?
Thank you. I think we didn't really hear much about caste intersections, but Arpana, is this something that you would like to elaborate on? Because I think she, in the review that we undertook collectively, findings related to caste intersections were a very evident gap in the studies that we reviewed.
Definitely.
So caste and the gender lens.
Yeah, just coming in to respond to Madhulika's question, that's a very pertinent point, because given the fact that how selection of ASHAs are done from marginalized community to be representative of community needs, that was in the times of COVID, because the focus was entirely on delivering a primary level care in terms of generating awareness, follow-ups, and identification of migrants and other vulnerable groups in terms of elderly and things like that. This aspect came out in several newspapers which were in local formats, but it in our evidence synthesis and none of the studies sadly were pointing towards a very evident finding around caste intersections with related to CHWs. Thank you.
Thank you. This could be an interesting area to think about, the double burden of caste and gender and so on in this context.
Indeed, yes.
Yeah. So when we were discussing around the implications for it, so looking at research further with an equity lens was something which we were hoping to discuss in our next activity, actually. So thank you.
Great. Anyone else from the network who may have done qualitative work or studies that sort of speak to any of this? All right. Great. In case if you have any other questions, please feel free to ask.
Also in some ways an evolving database and evidence review. So if there's studies that we've missed out on, let's say in this work, if there's work that you're doing that you would like to sort of send in, then you know that it will hopefully expand over the course of time. Thank you.
Definitely.
Great. In case that, sorry, go on, Radhika.
No, go on, Rohan. Sorry.
Great. I was just saying we could either maybe ask if there's someone from the working group who's here on the call and would like to reflect on how the overall summary reads with what they had found out, in case if there's anyone who'd like to share something. And if not, perhaps we move to the activity, which was again created with the intention to figure out, in case if as a group we feel like there might be other areas of focus that we should be looking at. I mean, one thing that came up today was, I mean, as Madhulika said, the intersection of caste and gender would be interesting to look at, but also in terms of, I guess, what would be most relevant to bring out, as Priya said, in terms of COVID-19 focus and moving forward as an adaptation. but also in general something that we produce together and will have maximum impact going forward. If you have any ideas on what should focus areas be, it'd be great if you could take this quick poll.
And just to add to that, Rohan, but something that we want to also flag here is that this is an evolving database, like and an evidence base that Radhika spoke about. So, for example, the suggestion about caste is really valuable, and I think that will just add more layers and more nuance to our larger narrative and the meta story that comes out of here. So perhaps this is also an opportunity to, in addition to identifying gaps, also opportunities where we can galvanize our efforts better. Thank you. That's all I wanted to add.
Great. So if I could just request everyone to spend the next 1 minute going on to menti.com and adding this code on the poll. And if you could add a quick response to this, that would be wonderful. Just going to start sharing responses from the Menti poll so we can all see. Great. Great. This is really useful. In case if there's anyone who'd like to share what they wrote and tell us a little bit more, because I know there was limited space on text. If anyone would like to share what they wrote to clarify. Or Radhika, in case if you have a question. All right, thanks for this. I think the key emergent theme that comes out is certainly supervision and what the future of that looks like, and as we and the gendered impact rate. I guess especially as we go ahead and there's better access to technology, and the definition of who a frontline worker is also something that is already in conversation, is expanding. This is lots of great input for this conversation to continue within and outside the working group. Great. Thanks so much for all of your inputs. I'm just going to stop sharing and reshare the main deck to just tell you a little bit about what we're doing in the next coffee hour session. This is on Tuesday, which is November 3rd, sorry. And we're going to be speaking with Dr. Mala Ramanathan and Dr. Subrato Mandal. And we'll talk about IRB adaptations. And I know this has been on top of a lot of our minds to think about how IRBs can set better mandates for researchers to operate within, and then how, especially when they move to phone surveys, how both researchers and IRBs are adapting. So we'll be sending out an invite for this at the max by tomorrow. But we'll also share with you a form where you can add questions in case if you have already thought of things that you'd want to ask Dr. Mala and Subrato to respond to. It'll be great if you could share that with us by Monday. And with that, I'd like to thank everyone who's shared their work with us in the working group, also the OPM team for working so hard and putting this summary together. And thank you to all of you for sharing this time with us. With that, I will.
Rohan, just 1 second, in case anyone has had anything, sorry to jump in as we're closing, but is there anything else anyone else wants to add to the word cloud right now before we close, in terms of, just pieces of work that you think we should engage in more on the evidence review to share in future, or anything else, any other comments that anybody has at this point before we close for the day? Okay, well, thanks. The word cloud has been very, very useful. And as Priyananda says, it does reinforce some of our findings now as part of the review, as well as some of the other CHW work that we have undertaken as part of OPM and as part of the thematic working group. And in terms of next steps, we are going to, we're still fine-tuning this evidence review, and it will be shared with thematic working group members. We're also sort of looking at some of the components mentioned earlier, which is policy engagement, to understand more deeply what the need for evidence is and how we can, as a thematic working group, generate content that is relevant to both program and policy. And of course, some of the inputs today, because CAST is something that has been very, very overlooked. That is something that will emerge, will be reflected in the work and in our findings as well now, and gender. So thank you very much for this. Thank you.
Thank you. Have a good evening.